Okay, good morning, everyone. Thanks, Dr. Patterson, for this introduction. Today, I will be talking about prostatic artery embolization as a treatment option for PPH. Our objectives today is to talk about the history of PAE and when this has started, and a few case reports who initially started this procedure, review the recent guidelines for PAE, discuss how it works, and go through what's new in the literature that was published last year about PAE. The two biggest two papers were published last year. So starting with history of PAE, it was initially started in the mid 1970s. It was mainly due to mainly for patients who had uncontrolled gross hematuria, either from prostatic or bladder origin. A few case reports were reported at that time, showing how successful it is to embolize the internal iliac artery and controlling these hemorrhage or this hematuria. But most of the cases did not report like uh, how uh, how good it is in terms of relieving the PPH symptoms or showing what are the possible adverse events of that procedure at that time. However, it was successful in terms of controlling the severe bleed hematuria from bladder or prostate origin. However, the first case report that reported the relief of PPH symptoms was in 2000. It was a case report of a 76 years old male patient with moderate PPH symptoms who failed medical therapy. He had recurrent urine retention, recurrent gross hematuria. Patient was high risk for surgery in terms of his cardiac status. He had dilated cardiomyopathy and congestive heart failure. And so eventually he underwent prostatic artery embolization. And a month later, he was voiding freely without any hematuria and without a catheter. So this is where the idea came at the beginning of the idea came through. This was the pictures from the first case report that reported the relief of symptoms. It shows a super selective microcatheter injection of the right inferior vesical artery with preservation of internal pudendal artery. Going forward, in 2008, this clinical trial used around 16 pigs. Uh, half of them underwent prostatic artery embolization, and then when they were reassessed 3 months later in terms of sexual function, then they had to take their prostate out and to examine it under with the histological findings. So the study showed that there was no change in terms of sexual function 3 months after prostatic artery embolization. And the good thing was the histological exam showed reduction in prostate volume, atrophy, and fibrosis of the glandular tissue, causing the prostate to shrink. And after this clinical trial, they suggested that this could be an option for symptomatic PPH in humans. In 2014, one of the earliest studies that compared prostatic artery embolization with TURP was a prospective randomized controlled clinical trial. They had around 114 patients, 57 in each arm, and they examined their functional status in terms of IPSS score, quality of life, peak urinary flow, post-void residual, PSA, and prostate volume over 1, 3, 6, 12, and 24 months. And according to their results, both arms showed a significant improvement in terms of all functional status. As we can see here, the IPSS score, quality of life, peak urinary flow, and post-void residual. However, the TURP group showed a greater and faster improvement. However, looking afterwards, like at 24 months, it was quite similar in both arms. Both procedure as well showed a significant reduction of PSA and prostate volume with a p-value less than 0.01. This is one of the earliest paper that showed that compared PAE with open prostatectomy. It was 1 year matched pair analysis of functional outcomes and morbidities. So they had around 80 patients on each arm, 80 patients who underwent open prostatectomy and 80 patients who underwent PAE. And both groups showed a significant improvement in almost all parameters in terms of IPSS score, peak flow, post-void residual. However, similar to TURP, the open prostatectomy arm showed greater and shorter improvement. This paper also reported the complications of each arm. Of course, open prostatectomy showed a bit of higher complications, mainly on grade 1 and grade 2, and PAE showed like 7% of complication. It was mainly of the like post-embolization syndrome and unexplained pelvic pain, dysuria, rectalgia. One patient who experienced a UTI after PAE. Then we'll go through a systematic review that showed the short and mid-term safety and efficacy of prostatic artery embolization. It was a systematic review that was published in 2015, included around 7 studies and over 560 patients. So all of the studies showed improvements from baseline in terms of IPSS score, quality of life, Qmax, total prostate volume at 6 and 12 months. And when they looked into the complication rates, like interestingly, most of the complications are minor, which is grade A. However, around 9% after PAE still experienced acute urinary retention, requiring follicular insertion for drainage. And when they compared bipolar versus monopolar versus PAE, like PAE showed the lowest rate of complication, however, the highest rate of urine retention. This is also one of the earliest meta-analysis that was published. It was over 15 years. They included 19 studies in their data collection, with 6 studies that was included in the meta-analysis, with over 425 patients were included. And as we can see, all studies here showed improvement in terms of prostate volume, post-void residual, maintenance of erectile function, and improvement in urinary flow, mainly Qmax. They also reported the complication rates, and as we can see here, most of the complications are minor. However, the urinary retention rate was around 7% of patients, and the non-specific pelvic pain or rectalgia and dysuria around, which is like post-embolization syndrome, was around 9% of patients. Later on, it was PAA was FDA approved for symptomatic benign prostatic hyperplasia in 2017, and 1 year later, AOA included PAE in their statement. The statement was PAE is not recommended for the treatment of LUTS attributed to PPH outside the context of a clinical trial. Moving forwards in 2018, one of the good papers that was published from a urologist in UK. It was comparing PAA with TURP. They included around 300 patients. 216 patients underwent PAE and 90 patients underwent TURP. Their primary outcome was IPSS improvement and identify the possible adverse event and complications. Their baseline characteristics in terms of IPS score was about quite similar. However, when we look into the prostate volume, the PAA group had a prostate volume of 101, and the TURP group much less, with a volume of 65. Then they looked at their functional status of 12 months post-op. IPSS was showing improvement in both groups. Erectile function showed maintenance of it was maintained in both groups. We did not show any changes. Prostate volume was not reported in the TURP group. However, it showed a great decrease on the PA group. However, the overall reoperation rate at 12 months showed it was significantly higher with the PA group. So 20% of patients who underwent PA had reoperation during their 12 months follow-up. The reoperation was either a second PA or an endoscopic procedure in terms of TURP or other alternative PPH surgeries. They also reported their other complications. Most of the complications are minor, as we said. However, they had one patient who had sepsis requiring IV antibiotics, and one patient who had a groin hematoma requiring blood transfusion. When they looked into the patient-reported outcomes, interestingly, like 25%, 24% of patients underwent PA had a retrograde ejaculation, despite like being a minimal invasive procedure, and was like told that it does not cause any retrograde ejaculation. However, 24% had retrograde ejaculation at 12 months post PA. So how does it work? It works by blocking the blood, suddenly blocking the blood supply to the prostate, causing immediate central infarction of the gland, causing shrinking and decrease in volume. And later on, delayed fibrosis will lead to further reduction and shrinkage of the prostate. So the pictures that you see here in this slide is from an adult male dog who underwent PA. And as we can see here, how the prostate is shrinked and fibrosed. Moving forward into one of the more recent systematic review and meta-analysis showing the efficacy and safety of PA for PPH. It was published in an European Radiology Journal in 2021. They included around 11 studies. I know it's a busy slide, but I'll try to go through it quickly. So this force plot showing the mean changes between each arm, which is the PA arm and the TURP arm, over 12 months. And as we can see here in the IPSS, quality of life and erectile function and Qmax, and erectile function. So the first three arms, the first three criteria was showing statistically no significant difference between PAE arm and TURP arm. However, when we looked into the Qmax, it was mainly in favor of TURP. When we looked into the post-void and prostate volume, it was mainly in favor of TURP arm. PSA showed no significant difference between the TURP and PAE group. They also reported the hospitalization. It was quite similar with one day overnight stay in most of the studies that reported this comparison. When they looked into the procedure time, it was also in favor of TURP, as it is a much shorter time than PAE. And they concluded in their studies that PA is non-inferior to TURP in regard to patient-reported outcomes, although most functional parameters undergo more changes after TURP rather than after PA. This is one. This is the largest study that I found in the literature. Um it is from the United States. It's compared the prostatic artery embolization compared to TRP and prostatic urethral lift. It's a real-world population-based study that included around 12,900 patients who underwent these procedures from 2014 to 2018. And their primary outcome was 1 month and 3 months readmission to inpatient or ER, long-term reoperation, long-term structure development. However, it was this study was limited by they did not report like the baseline characteristics for each arm, and they did not report the prostate volume or whether the patient was taking any PPH medications or not. So the results were showing that PAE showed the highest rate of 30-day readmission to inpatient or ER, the highest rate of 30 days readmission to inpatient or ER with complication, the highest rate of readmission to inpatient or ER, and the highest rate of 90 days readmission to inpatient or ER with complication. When they looked into the reoperation rate, also PAE showed the highest rate of reoperation at 6 months, 1 year, and 2 years with a significant p-value. And when they looked into the structure, of course, it was higher on the TRP group. And they concluded in their study that in this real-world population study, PA showed the highest risk of 30 days and 90 days readmission to inpatient or ER, and has the highest retreatment rate of all surgical techniques when controlled for individual patient comorbidities and surgical volume. With the latest AUA, they published an updated statement about PAE, which is PAE may be offered for the treatment of plus PPH. PAE should be performed by a clinician trained in this interventional radiology procedure following a discussion of the potential risks and benefits with a grade C recommendation. Going through a few case reports that reported PAE and how successful it is for something that is not PPH related. So this is a paper that was published 2 months ago of a case report of a patient who was 40 years old, who had a vasectomy 6 years ago, then presented to the clinic with recurrent hematospermia without hematuria. He was treated with medical therapy, alpha blockers, antibiotics, behavioral therapy, and it did not show any improvement. MRI showed symptoms of a picture of chronic prostatitis with a prostate volume of 26 and seminal vesicle hemorrhage. Patient underwent PA, which was done later on 2 weeks ago. 2 weeks later, he showed significant improvement in terms of his hematospermia. Looking into PA with prostate cancer, this is a systematic review that was published in 2023 in the European Journal. It was showing how PA will affect prostate cancer in terms of functional outcome and oncological outcome. It was a systematic review from 1985 to 2022. They included around 13 studies, and like all the studies showed, PAE is safe and effective in reducing or improvement for LUTS symptoms in patients with prostate cancer. However, like similar to the general population, however, it did not show any oncological benefit or any change in tumor response for patients with localized or advanced prostate cancer. Looking into the cost of PA, this paper was published in 2017 in the United States. It was showing the difference in cost when doing PAE versus TURP. They compared around 86 patients who underwent TURP versus 70 who underwent prostatic artery embolization. And as we can see in these tables, the intra-procedural supply for PAE was significantly more costly than TURP. However, when we include like the anesthesia, the OR booking, the nurses, the overnight admission, TURP showed a significantly higher number, like 5,300 versus 1,600 on the PAE group. We will conclude our talk with the latest two studies that was published last year. This is one of the largest studies. They included around 1,000 patients, and they reported their mid to long-term outcomes. So they had around 1,000 patients and at the University of Miami. Their mean follow-up was around 15 months. And interestingly, like they told patients to continue their PPH medication until 1 month after prostatic artery embolization. So looking at the baseline characteristics for these patients, they had a prostate volume of around 107 and IPSS of around 23. And comparing the baseline to the 48 or 60 months, it showed statistically significant improvement for IPSS score, quality of life, and a reduction in prostate volume was around 20%, and maintenance of erectile function score. However, and interestingly, like at 6 to 12 months, it showed some improvement in terms of erectile function score after PA. Also, this graph shows the changes and how the improvement was in post-void residual IPSS score and the maintenance or slight improvement in the erectile function score. They also reported the complications. However, this study, they reported that around 1% had severe prostatic artery embolization adverse event, including prostate sloughing, requiring TURP, 3 patients who had stroke, and 2 patients who had urosepsis requiring admission and IV antibiotics. However, the retention rate was was much less than the previous studies, around 3%. 16% of their data of their patients had re-intervention after PAE by 60 months of follow-up. So we will conclude our talk with this latest study that was published in 2024, comparing prostatic artery embolization versus TURP over a 5-year outcome. It was a randomized open-label non-inferiority trial. It was published from a Swiss tertiary care center from 2014 to 2017, and their primary outcome was the change in IPSS score after PAE versus TURP, and their secondary outcomes was reporting the patient's reported outcomes, functional measures, and adverse event at 3, 6, 12, 24, and 60 months. Their baseline characteristics were quite similar. Prostate volume was around 50 in both arms. And looking into their results, as we can see here, PA and TURP showed significant improvement in terms of IPSS score, quality of life, and chronic prostatitis symptoms index. However, the TURP group showed a significant, a greater and a shorter improvement. I mean, faster improvement. They also looked into the Qmax and post-void residual. It was significantly higher with the with the TURP group. However, as looking forward at 60 months, it was not showing any significant difference. So both groups improved in terms of Qmax, post-void, and reduction in PSA at 60 months of follow-up. And they concluded that the improvement in LUTS and PPH after 5 years uh, after BA was inferior actually to that achieved with TURP, and the limitation could be like patient selection and patient counseling. So, despite all the conflicting findings I found in the literature between like the radiology journals and the urology journals, I think I can conclude with PAE is safe, effective in reducing LUTS, but it is not as good as surgical alternatives. PAE is effective in preserving sexual function and somewhat antegrade ejaculation. PA is advantageous for patients with coagulopathy and high risk for surgery. PA is effective in treating patients with hematuria of prostatic origin. And thank you.